Good evening. Thank you for joining us for OSC's Community Lecture Series. My name is Chelsea, and I'm part of the OSC marketing team. Tonight, I'll be interviewing Dr. Robert Snyder about patient-specific knee replacements. We're also lucky enough to hear him briefly discuss hip replacements tonight. Dr. Snyder has been with OSC for 26 years and focuses on total joint replacements. He began his medical experience in the U.S. Army, finishing his career as the Chief of Orthopaedic Surgery at the United States Military Academy at West Point. OSC is lucky to have this Lieutenant Colonel. Good evening, Dr. Snyder.
Good evening, Chelsea.
I may be able to hear just a little bit that we're in the same room. We are both here at OSC, but for social distancing practices, we are a little bit apart. Can't see the next slide tonight. Dr. Snyder will be taking questions throughout the talk. If you have a question, please type them in the Q&A box on your screen. Visual instructions are on the screen for your convenience. Dr. Snyder, I wanted to lead with a pressing question. This year is being defined by COVID-19, and many patients have a concern about receiving the medical treatment they need to protect themselves from the virus. Can you tell me what OSC is doing to protect patients and staff members against COVID-19? And what would you say to a patient who is at home right now in pain, waiting for COVID to pass before seeking out care?
I would tell a patient at home waiting with pain that although I guess we can't make everything 100% absolute, we can certainly mitigate most of the things that are going on today. We all wear masks, and patients wear masks in the room. We, unless there's an extenuating circumstance, only have the patient in the room with us, no other family members. We make our patients check in by a mobile app and wait in their car until they're called in individually, taken down to X-ray, and then brought into the office where they are examined, and then prescriptions are sent, and their plan is discussed with the physician. At that point, they leave. So we are practicing social distancing. We are wearing masks. We extensively clean and wipe down all of the tables and chairs in between patients. We also, at the end of the day, have a cleaning crew that goes through the building from top to bottom, sanitizing and cleaning. So again, although we can't certainly be 100% effective, we're hoping to be at least up in the 99.9%.
That's great to hear. And I do see our team constantly cleaning. I do see that our mobile check-in system is really helping streamline check-in for patients and keeping the minimum number of people possible in our office. Just a reminder, if you have any questions, please type them in the Q&A. Dr. Snyder will be answering those questions through the lecture. I want to move on to the big topic of the evening, and a big part of what affects the knee is arthritis. Can you tell us about arthritis and how it affects function?
Certainly. Before we talk about the arthritis, I'll give the 10-second overview of the knee, and we have a diagram of the anatomy of the knee up there. The knee is basically composed of three chambers. The inside of the knee, where most of our weight goes when we walk, the outside or lateral compartment, and the patella, which assists us in going up and down stairs and bending our knee. All of the bony surfaces are covered with the articular cartilage, and then between the articular cartilage of the femur and of the tibia bone, we have meniscuses, which is a type of pliable cartilage that is essentially, we view it as a shock absorber. As we grow during childhood, our cartilage can grow. If we injure our cartilage and we're age 3, we can, as we continue to grow, heal a cartilage. So by the time we're an adult, the cartilage on our knee would be essentially back to normal. Likewise, during our growing years, the cartilage can repair itself. Of course, as we get older and start aging, the cartilage decreases with age, and it's analogous to the wear on a tire. As the tire gets more revolutions and stays in service longer, the rubber gets thinner. The same thing happens to the cartilage in our knee. So when we look at on the left slide, we see a normal knee with glistening, shiny cartilage. And the cartilage in our knee is probably between 1/8 of an inch and 1/4 of an inch thick. Now, as we age and the cartilage wears away, certainly the thickness can decrease, or in certain cases, like the slide on the right, the cartilage totally disappears, and the reddish areas that you see are represented by bare bone. If we look at that on an arthroscopic view, on the slide on the left will depict basically a healthy knee that has one area where the cartilage has been damaged, and underneath that we see the bare bone. If we go to the arthroscopic view on the right, we see a knee where almost the majority of the cartilage is totally worn down to bare bone, as depicted here. If we look at an X-ray on the right, we see a normal space on the inside of the knee and the outside of the knee. Whereas we look at the X-ray on the left, we see that once all the cartilage is removed from the knee on the inside, an X-ray shows typically bone on bone, and we hear a lot of patients, or we express the X-ray findings to patients and insurance companies as having bone on bone arthritis, which would be depicted as the slide on the left. The question then becomes, we all have arthritis. We all have it in varying degrees. It can start early in our life, and certainly it can continue for many years. And what is basically the common sense treatment? Well, common sense things would be just over-the-counter, Aleve, Advil, Tylenol. We could certainly get into the fancier prescription type anti-inflammatories. And there's a variety of those that we can take. Some of them are once a day, others are twice a day. Some you have to take up to 4 times a day. Of course, we can apply ice and ice down our knees. That's the common sense treatment when we injure ourselves. Taking supplements like glucosamine, which is a component of our normal cartilage, has been shown to help, but again, it will not grow cartilage. It will help you maintain basically what you have. Exercise has been shown to help arthritis. Not only does it stress the joint and allow the joint to move and go through its entire range of motion, but exercise at a young age while our cartilage is still growing actually allows our cartilage to get thicker. Of course, once we stop growing, that's no longer the case. Weight reduction will also help, and that makes common sense. If I weigh 100 pounds, I'm putting half the weight on my knees that someone who weighs 200 pounds, and hopefully my knees will last longer. Finally, we hear about injections into the knee. They can take many forms. They can be either steroid injections. We can do lubricant type injections into our knee. And then ultimately, we have our surgical options, and those vary from just arthroscopic procedures, which are basically in and out type surgeries, where we can remove a meniscal tear. We can often repair a meniscus. We can debride or just basically clean up the joint. Again, we can't put anything in the knee yet that will grow cartilage, but we can certainly extend the life of your knee. We don't do it very often anymore, but years ago, we used to do osteotomies where we would basically cut the bone and shift it so that it would shift the weight from maybe the arthritic portion of the knee, as is depicted in the slide here, to the outside of the knee. But again, these are rare and usually reserved for somebody who is too young to really go through a total knee, but still is expected to function and continue to work. Ultimately, a decision is made to proceed to knee replacement because the arthritis is in the knee. There's no cartilage left in the knee. The pain is such that we can't control it with medicines, injections. So what is it? What is basically a knee replacement? Well, a knee replacement is basically plastic bearing that's between the metal components on the femur and on the tibia. Knee replacements can be cemented utilizing a very tough type cement, or the components of the knee can basically be roughened so that they're non-cemented or pressed into the bone, which allows the bone to grow into the joint replacement and hopefully eliminating the occasional knee where the cement might break down or become loose. Knee replacements, of course, are limited, come in limited sizes, just like shoes, to basically fit everyone. Knee replacements also come in gender differences to fit the difference between the bones of a male and female about the knee. We make relatively large cuts in a traditional knee replacement, so of course, once we remove the bone, it can't be replaced. And then the biggest question in a traditional knee replacements is how long is this going to last? And basically, this is what's driven research into new types of replacement. How can we make the plastic better? How can we make the metal better? So a knee replacement is going to, how long a knee replacement it lasts will be subject to, well, the trauma on the knee. If I put a knee replacement in someone and they go out and have a severe auto accident and basically damage that knee, they may in fact be damaging the knee replacement also. We've talked about the normal wear and tear. Metal doesn't wear, but certainly plastic does. And over the years, we've attempted to make the plastic much stronger and more durable that's in the knee replacements. Your weight will also greatly influence how long the knee replacement will last. The more you weigh, basically, you're probably looking at a knee replacement that might wear out sooner than if I do a knee replacement on somebody lighter. There are surgical factors that might influence the longevity. One being the quality of the cement that was mixed up. Others being maybe some bleeding into the knee that might interfere with the cement setting up. And then the one that I have the asterisk by is basically alignment. Out of all the factors that influence the longevity of the knee, probably the most important is how accurately the knee is placed. Ideally, that's what drives a lot of the research nowadays. We know that if the knee a knee replacement is off by a few degrees, horizontally or vertically, that increases the stresses across that knee and will prematurely wear it out. So a lot of the research that goes into knees are looking at ways that we can improve on the alignment. Number one would be robotic surgery. In other words, program a computer and let the computer make the cuts, and we sit back and control the computer. And there are things like that, that can be brought into the operating room. Of course, it adds another layer of equipment that needs to be brought in, equipment that needs to be maintained, equipment that needs to be set up, and certainly adds another cost to the surgery, and also adds a lot of time. Computer navigation are devices that are brought into the operating room where basically we can hook up a sensor to a drill or to a saw, and we can then hold that saw against the knee, look at a computer screen, and basically know if we're going to be off a degree or 2 degrees, and we can try to make our cuts as accurate as we can. Of course, again, that adds a lot of time to the operation, and that adds a layer of complexity to the OR crew. The last is custom implants. In other words, instead of improving the alignment in the operating room, well, let's improve the alignment outside the operating room. And this is where custom implants become involved, where the implants are custom made to your knee, and all of the appropriate items that we need in the operating room to put that knee in place are also provided by the company that makes the custom knee. A lot of my talk tonight is going to be about a company that I've been using for, well, probably 15 years now, pretty much exclusively, called ConforMIS. And ConforMIS basically is the only true patient-specific joint manufacturer. They are now manufacturing custom-made knees, and also we'll discuss briefly at the end custom-made hips. When I say custom-made, I mean that their knee or their hip is going to be designed one at a time and built one at a time, and it's going to be built to the same contours that your knee has, or your knee had before it really developed arthritis, so that it restores the alignment and the functions to your knee like it had before it had arthritis. So it combines the best of both worlds. At ConforMIS hips and knees, for knees, they have partial knees that basically only replace that part of the knee that has arthritis. And it's surprising how many patients who in our country who get total knee replacements that basically replaces the entire knee probably have arthritis in only one main area of their knee, and might in fact be candidates for partial knees. Of course, total knee replacements and total hip replacements replace the entire knee joint or the entire hip joint. Again, they are the only custom patient-specific system on the market at this point. They call their technology the iFit, and basically it begins with a CAT scan of your knee. Seems like we're having some trouble here. I'm going to try to get this iFit screen up there. There we go. So this is an animation of a knee with arthritis, and you can see where the bone or cartilage is worn away and the exposed bone, and they've done a CAT scan of that knee, and basically utilize the CAT scan to make a model of your knee. And then they map the knee replacement onto your knee, and individualize the implant, which is now depicted here in metal. So it basically is the same model that they customized your knee is now made into the actual metal. And then they've customized the jigs or the cutting blocks that you see depicted on the right. So when you go in for surgery, the jigs fit right on the diseased knee, and you have guides to make very accurate cuts with. And as depicted here, the cuts have been made, and then finally the knee replacement is glued into its proper position. So what does that mean? For the surgeon is basically after all of these things are done at the factory, a patient's knee replacement is sent in a box, and inside that box is what's depicted on the bottom. It's all the actual pieces that will be left in the knee, plus all of the white disposable plastic pieces that are used during the surgery to make the appropriate bone cuts and to put the knee in an accurate position. And once those are followed, of course, then we've recreated exactly what that computer model has created on your own knee. Now, the hospital does have to provide some basic equipment, so that's shown in that box at the top, but it's not nearly the amount of equipment that is supplied with other non-patient specific knees. The box we see here is a box that comes when you have a patient specific hip. It'll actually have models of the diseased hip, so that you can utilize some of the plastic jigs against that model to see the orientation, and then as you then put that jig onto the patient's own diseased hip to make the appropriate cuts. So what would an ideal hip and a knee system be if we had to basically all sit down and design one? And number one, we'd want to preserve as much bone as we could in both the hip and the knee. We'd only want to replace the worn areas, and importantly, we want it to move like a normal knee or a normal hip. We want to have reproducible, proper alignment, short hospitalizations, less pain, fast recovery. We want it to last a long time. And the last is we want to make it. We want that new knee or that new hip to feel like it's part of us and feels natural. So we're going to look at a few basic studies about knees, and the graph basically shows different things that people participate in, from squatting all the way to swimming, biking, cross-country skiing, and it shows the number of people who responded who are showing no difficulty with it. Well, let's take for example, gardening. About 55% of control subjects who basically do gardening report no problems, and patients that have had knee replacements traditionally, only maybe 15% of them report no problems. So as you can see, there's quite a mismatch between patients who have had knee replacements and what they can do compared to patients that haven't had knee replacements, again, looking at traditional knee replacements. So there's been multiple studies looking at patient satisfaction. And the bottom line is that, probably 25% of patients who have knee replacements certainly can walk, they certainly function, but they're not totally satisfied. So we're trying to get that last 25% of patients and see what can we do so that basically every patient who has a knee is satisfied. Well, when they've looked at traditional knee replacements, and again, we're not looking at ConforMIS knees. One of the things is just overhang. Again, traditional knee replacements come in pre-made sizes, as depicted, and some traditional knees, the part of the knee replacement may overhang the natural knee. Well, a ConforMIS knee is matched to your anatomy. So, if your knee is a little wider in one area, then your knee replacements made by ConforMIS will also be made wider in this area. In other words, the ConforMIS knee is going to try to cover, every bit of area in your diseased knee where there was cartilage. The other thing that throws traditional knees off is how the tibial component is placed. I think I have another slide here. Well, I don't see that one. Well, let's go back then and back to our study. And I'll back to new share or pause share. Pause share.
You want to go back one screen?
Back to our normal slides. There we are. I think this will fix it now.
Okay.
So we're talking about the tibia, and with the traditional knee replacements, if we mismatch or turn the tibial component in too much, they're 5 times more likely to have knee pain. So there are a lot of things that are done with traditional knees that the surgeon, in trying to obtain the best fit, best coverage, may inadvertently put the tibial component in too much rotation, and this interferes or has a big effect ultimately. And it's depicted here on the left is that that's a component, the tibial component, which is purple, has been is in an attempt to get maximal coverage. The knee has been internally rotated, where on the right is showing proper rotation, but the surgeon has had to basically go to a smaller component to make sure it's pointed in the right direction. Again, with a personalized knee replacement, as is depicted on the right, we can see that the tibial component comes in the exact same shape that your own knee is, and this assures that it will be put in a perfect alignment. The other thing that's unique about ConforMIS knees is that they build in both curves in your knee, whereas traditional knee replacements only build in the medial curve of your knee. If we look at a knee from the side, there are actually 2 curvatures. The inside of your knee has a larger diameter than the outside, and the ConforMIS knee is the only one that puts this in. The ConforMIS knee also, because it's made for your knee, increases the amount of the metal that's actually contacting the surface of the bone. Without going into a lot of detail, basically there's a comparison of the surface area at different degrees of flexion. The ConforMIS knee, which is the left knee, the left bar in all 3 of those annotations, has more contact area. The more contact area, the less stress on a knee, and the longer the knee will last. Well, it all sounds good in theory, but what about actual patients? And there have been some studies that have looked at traditional knee replacement compared to a normal knee replacements, and basically showed that the patient-specific knees, ended up providing neutral alignment, which was the goal in about 84% of the patients, a much higher percent than typically in traditional knee replacements. The other 10 patients, were again plus or minus 2 degrees, no outliers. Postoperatively, full extension was obtained in all the patients as measured with a navigation type. Again, the other studies looking at 100 knees compared to 100 off the shelf found that the I total was 1.8 times more likely to be within plus or minus of 3 degrees of neutral alignment. Another study looked at how long the procedures looked, the length of stay in the hospital, how much bone got resected, KCC, which is a knee score based on things you can do after your knee replacement, and blood transfusions. In all areas, the ConforMIS knee beat the traditional off-the-shelf knee in the amount of time to walking, 5.2 days to 6.9 for an off-the-shelf, going upstairs and bending the knee to 90 degrees. These were all statistically significant. They hooked up knee replacement patients to X-ray or fluoroscopy screens and had them actually try to walk on a treadmill while live X-rays were taken of the knee. And again, when they did this study and looked at the off-the-shelf knee replacements, on average, they received had more degrees of freedom than the off the shelf. Basically, when they looked at how the knees were sitting and the alignment and how the knees worked. And I know this is a tough slide to interpret, but basically it showed that on the left slide, the custom-made knee, as the knee bent, the knee did not really, it slid as much as it should anatomically, not excessively like the off-the-shelf knees on the right did.
That's great. Dr. Snyder, while you're at this stopping point, I do want to encourage anybody who has a question to go ahead and type it in that Q&A box. The instructions are on your screen. We do have a couple of questions who have come in, and I do want to go ahead and ask those. We have one question. A 78-year-old male with osteopenia would like to know, he has severe osteoarthritis of both knees and both hips. Should surgery be done on one before the other?
Good question. Patients often ask that question, and I have 2 knees that need to be replaced. Can I do that at the same setting? And really, that comes down to your overall health. If somebody is very healthy, has good upper body strength, does not have a lot of underlying medical problems, it is possible to do 2 hips at the same setting or 2 knees at the same setting. However, if someone has medical problems or perhaps might not have enough upper body strength to help themselves getting up with a walker and doing things they may need to do post-operatively, they're usually going to be recommended for staged procedures. And if you have a staged procedure, you'll have your most symptomatic hip or knee done first, and typically we like to wait about 3 months until you're recovered enough to where you can have that second knee done. So it's not really the osteopenia that would prevent 2 knees or 2 hips from being done at the same time. It would be issues like your cardiac reserve, history of atrial fibrillation, or other comorbidities.
Perfect. We have one more question so far. Are any ligaments cut with the custom fit replacement?
The answer is no. No, we all knee replacements will preserve the inside and outside ligaments, so the medial or lateral collateral ligaments to your knee, and the posterior cruciate ligament is typically preserved when someone does a constrained type knee replacement. There are types of knee replacements, and ConforMIS has one where the posterior cruciate ligament is also cut. The anterior cruciate ligament knee replacement systems have enough built-in stability that the anterior cruciate ligament is sacrificed, and this usually is due primarily to the exposure. There have been a few trial or a few, I would almost call them not experimental, but there I think is one system out there that tries to preserve the anterior cruciate ligament. But the anterior cruciate ligament, if we think about it, is typically something that you need to be able to run, cut, play sports like basketball, football, and most patients that are getting their knees replaced are not going to be participating in those activities.
And I think that's all the questions we have so far. We'll take up some more questions at the end. Following ConforMIS's success in knees, I hear they've moved on and started a hip replacement. What is the difference between the hip and the knee replacement?
Well, I think knee, everybody's knee is shaped differently, and we can feel that. I mean, we can look at our own knee, and we can look at other patients' knees. Some people have bonier knees than others, and some people have a difference in the angulation of their knee. Some people are naturally knock-kneed. Some people may be a little bow-legged. Hips are a little bit different. We don't really see a patient's hip. A hip is traditionally thought of as basically a round ball and a round socket. Of course, as we go into talking about patient-specific hips, we'll see that there are some variabilities, or a lot of variabilities in hip surgery, but they're not as evident in looking at a patient. But we see them when we look at the x-rays or when we do the actual surgery. So getting back to some of the answers, some of the things we were talking about in knee replacements, and some of the conclusions from the studies that have been done was that, yes, we preserved 27% more bone. There were fewer soft tissue releases required. Less operative time, less blood loss, less swelling. There were 0 blood transfusions that were required, and the custom knee score was higher than the traditional knee replacements, and patients typically went home a day sooner. Well, again, nowadays we're doing most of our knee replacements as outpatients or as home the next day. So this is important because the patient-specific knee should, in theory, allow you to have that same-day surgery, or certainly be able to go home by the next day. We look at the traditional delivery system. Well, we don't get too involved in this as surgeons, but the companies that make knee replacements and make the instruments required to put them in have to bring in about 10 to 12 trays of specialized instruments, as you can see depicted here on the picture to the left, that these trays contain all of the trial sizes for their knees, plus all of the bearings and everything that goes into a knee replacement. There's the knee replacement examples on the left and the hip replacement examples on the right. So all the trays have to be opened up. They all have to be set up. After the surgery's done, they all have to be sterilized, broken down, and then packaged for another operation. The ConforMIS system is basically starts out with a CAT scan of your knee. We submitted a request form. Your CT scan gets converted to a 3D imaging. The knee replacement and all of the components are then manufactured, and basically it's all put in a little box and sent back to the surgeon. And this is usually done within about 4 weeks. And again, everything's in that box that the surgeon needs. Usually the hospital has to supply some basic instruments that they all have, and they all keep a lot of them on hand. So there's not the 6 or 7 trays coming in. There's not the times when they open a tray and find that it's maybe not truly been sterilized and has to go back and be re-sterilized, which certainly adds time. When the ConforMIS hip or knee comes, it's all sterilized, it's all packaged, and it all basically comes with everything it needs to be put in there. We're going to talk a little bit about hip replacement. Hip replacements for ConforMIS started after knee replacements. Hip replacements is now one of the most common types of orthopedic procedures. And I've heard hip replacement described as economically as the best or most optimal type of surgery, and how much it actually costs to do, and how much much better the patient is after the surgery in the fact that they can continue to work and perform and function basically in a normal capacity. So we look at the X-rays on the left, and basically the ConforMIS hip starts out the same way. It starts out with a CAT scan that goes from just above the hip to just below the hip. The hip is made in a 3-dimensional model, and then the actual pieces are made, and the actual pieces utilize the same things that we use other manufacturers use. They use the metal press fit cups that don't need to be cemented. They use the metal press fit stems that don't need to be cemented. And they use the ceramic head balls, which basically line up with the plastic cup that's inside the metal acetabulum. But then you're asking yourself, well, what makes it specific? To me, it looks like it's a round ball in a round cup, and it basically is, except you've got to remember that that cup can be oriented differently in every different patient. Some patients, the cup may be oriented as you see on the left side on the green, or in some patients the cup may be more open to the front or more open to the back. We call that anteversion. So when we talk about anteversion, the cup either opens up a little bit more to the front or a little bit more to the left. The other thing that's variable about the cup is the angle that the cup makes with a horizontal line. As we can see in the picture on the left there, that line is typically about 45 degrees, but it can vary from anywhere from about 40 degrees to probably 55 degrees. So there's a lot of variability within patients. The other variability is within the stem, the part of the hip replacement that actually goes down into your proximal femur. As depicted here, the stem is going to be supposed to end up in an ideal situation with the head ball being the same position that the head ball was on your native hip. So the stem is going to have the same angle built in into it as your natural hip did. Again, depicted in a normal hip or in a natural hip, like depicted on the left. That angle typically can vary from around 120 degrees to 135 degrees. So here we see a picture of a patient-specific hip on the right. The other variability is if you look at your hip basically from the ceiling, looking down the shaft of your femur, there's an angle that's called anteversion that varies from individual to individual, as depicted on the left, from where the actual metal stem is to where the red drawing is. So again, variability doesn't vary much from patient to patient, but it varies enough to make a difference. So if you add the fact that patients' acetabulums may be angled differently, they may be oriented front to back differently, your own femoral head may have the angle that the ball takes off from the shaft, and put all these things together, then you can see where ConforMIS fits that niche of filling something that's perfectly will fit your hip, as opposed to using off-the-shelf hips, which are basically a blend of the average the average stem, the average neck length, the average inclination of the cup. So when the ConforMIS hip is manufactured, they manufactured unique tools that the surgeon can use. As depicted here, there's a plastic disposable jig that fits the anatomy once you expose the head and neck from the hip, and basically will allow the surgeon to make that cut of the head exactly where it needs to be cut, so that you can put the stem in the proper position. Likewise, the cup will be placed exactly as it was in your native hip, the same orientation. And the stem is designed to fill all of the crevices of the proximal femur, as is depicted here. Again, these are all made to fit your knee, and they come in a little box. And of course, ConforMIS realizes that during the surgery you may encounter someone who needs a head ball that might be a little bit bigger than what they planned for. So they do include extras of some of the items, like the plastic cups, so that there is some variability within the system, and you can make minor adjustments. So we've talked briefly about knee replacements and hip replacements, and I like to talk about, well, what can you expect as a patient? Well, you could expect to come to the office, and it may not be one time, maybe multiple times, and you're being treated for your hip or your knee, and ultimately a decision is going to be made to proceed with a replacement. You're going to be sent to the hospital prior to the surgery to have lab tests done. If you've had a cardiac history, you might need to be seen by your cardiologist to get clearance. And doing this stuff before the actual day of the surgery allows us to repeat studies that may come back abnormally, or to address things that may come back abnormal prior to the surgery. The day of the surgery, you don't eat anything after midnight the night before. You show up usually 2 to 3 hours prior to the surgery. Again, your surgery will be during the day. You'll usually, after the surgery, spend some time in the recovery room. Ultimately, go to your hospital room, and some patients may go directly home from there within a few hours. Some stay overnight and may stay overnight 1, 2, or even 3 nights. Some patients still do go to a nursing facility or skilled nursing facility if they have additional medical problems or don't have somebody at home that can take care of them. we'll see you back in the office typically at the 2-week mark, the 4-week mark, and at the 6-week mark, and then see you yearly thereafter. It's usually recommended if you've had a hip replacement or a knee replacement that afterwards, if you go for routine dental work, that you'll take some antibiotics. Sometimes that's a little controversial. Some people think you need them for a few years. Other people are more of the opinion that you need to take antibiotics, basically for the rest of your life for routine dental work. I tend to fall in that line that it's never why take a chance. It's easy enough to take a few pills an hour before you have your teeth cleaned and prevent an infection, then have your teeth cleaned, get bacteria from the gums into the bloodstream that may lodge itself against a knee replacement. Get that out of there. I think the next slide is basically questions, and so we can stop here and hopefully fix that. Here we are, questions, and I appreciate the opportunity to be able to talk to you tonight. If you have any questions, please ask them. If you can always make an appointment to come to our office. I'd be happy to discuss and examine you and see if you're a candidate, or see if perhaps you may not need to have your knee or hip replaced. You may be other things we can do short of a replacement to help you. So answer questions if you have them, and we'll be around here for a few minutes, I guess, to answer things. And I'll turn it back over to Chelsea.
Yeah, we have a couple of questions on the Q&A. The first one is, do all of the doctors at Orthopaedic and Spine Center use the ConforMIS knee?
The answer is no, they don't. Usually in orthopedics, you have a tendency to utilize the equipment that you learned during your residency or fellowship. We all realized that we were comfortable learning on one system, and I've made the commitment to learn a new system because I honestly believe it's a better system, and it's in your best interest. If we just look in general about technology, I mean, technology is changing around us, on a constant basis. And the same thing applies to knee replacements. So I think we all, it behooves us all to stick up with the latest technology. And to me, the latest technology in hip replacements or knee replacements are coming from the customization of these things. I think pretty soon, we'll be able to grow an ear for you, or we'll be able to maybe grow another body part and transplant that to you. That's the way things are moving now with this DNA sequencing and the other advances we're making. So I think once the decision is made to have your hip or your knee replaced, to me, the customization and the patient specific shows advantages not only for the surgeon, but as I've tried to point out to you as the patient, more importantly.
It sounds like really great technology. Our next question is, if I get a partial knee replacement, can it lead to a total replacement in the future?
The answer to that question is it can, and the decision to put in a partial needs to be made in a very logical fashion by looking at certainly the rest of your knee. I myself have a partial knee on the outside of my knee, and I was about 60 years old when I had that. And I did that primarily because the outside of my knee had bone-on-bone arthritis, yet the inside of my knee and my kneecap had no arthritis. Now, should I have said, well, what's going to happen in 20 or 30 years and done a knee replacement? And some people would probably, feel that way. But I always tell patients with partial knees that, if you've made it 60 or 70 years and the only arthritis you have is in one area, then there's a good chance that's going to be the only area that, that you're going to need to be replaced. And so if I think that somebody has, arthritis in other areas of their knee, we're certainly going to sit down and discuss that. And if there's any doubt, we would probably do a total knee as opposed to a partial knee. One advantage of a partial knee is that it gives you more options in the future. If you start out with a partial knee, you can always convert it over to a total knee replacement. And if you start out with a total knee replacement and have problems with that, then that requires taking out that total knee replacement and putting in a supersized revision type knee replacement system. And once you go to something like that, you've got to be careful, because you don't want to, do anything to that might, cause that to have to be removed.
Very nice. I think this is the last question of the evening. Where can I read more about the ConforMIS knee replacement? I will start off the answer to that question, just let you know that at www.osc-ortho.com, we have a blog section, and there we have several articles. If you type in the search bar ConforMIS knee, you will find articles by Dr. Snyder talking about this topic. But then I can defer to you and ask if there's anywhere else they can look.
Yes, you could go directly to the ConforMIS website, which would be www.conformis.com. If anybody is looking at this who's not in our, that doesn't live in this area, that maybe live someplace else, they also maintain a list of surgeons throughout the country that are familiar with the ConforMIS system. So if you have a relative someplace else that lives in another area of the country, there are certainly doctors and orthopedists who do ConforMIS knees in just about the entire country at this point.
Wow. Thank you all for your questions. This evening's lecture has been very informative, and I hope everyone at home has found these answers to your questions. Dr. Snyder is accepting new patients, and to make an appointment, you can either hit the yes button on the poll on your screen, or you can call our office at 757-596-1900. Just choose option 5 to speak directly to the scheduler. OSC is conveniently located in the Port Warwick area of Newport News. We welcome patients from all over the extended Hampton Roads area and accept most major medical insurance companies. To learn more about Dr. Snyder, Orthopedic and Spine Center, and read articles from Dr. Snyder, visit our website at www.osc-ortho.com. We look forward to seeing you in our office. And if you have any questions, please feel free to email or call us. Have a great evening, and thank you for joining us.